Thank you. At the outset, I'd like to thank the organizing committee for this opportunity. So my talk today is on the management of complications in SMILE, both the common ones and certain rare ones as well. So we all know that the Visumax is a femtosecond-based laser procedure, because of which there might be an incidence of suction loss. The fact that the applanation is softer and the laser pass is longer vis-a-vis the femtosecond LASIK, it could probably increase the incidence of suction loss. Now, in all cases of suction loss following SMILE, the procedure can be continued with certain variations in the parameters. The only exception remains when more than 10% of the posterior cut, which is the refractive cut, is complete, and one has to convert to a femtosecond LASIK. Now, while doing so, it can be done within the same sitting, and one can use the same patient interface. Since you're using a small cone, the maximum diameter that you could get is around 7.9 millimeters. So the centration here is of utmost importance, especially in astigmatic corrections. This is a case of a suction loss during the cap cut. You can see that the posterior lenticule cut and the side cut have completed. This irregularly enlarging tear film meniscus is a sign of impending suction loss. The procedure can then be continued from the cap cut, and the remaining steps can be proceeded with as normal. Now, there are certain cases wherein the corneal side cut may not form well because of the tear film being excessive or the conjunctiva encroaching and interfering with the femtosecond delivery. One can use a surgical blade in order to open the corneal side cut and gain access to the lenticule. This is an uncommon or a rare case that I wanted to discuss, wherein the suction was unstable, but enough to let the femtosecond laser continue. You can see that there was a superiorly encroaching conjunctiva here, which had interfered with the delivery, subsequent to which there was no corneal side cut. So in this case, we used the Circle software, pattern D, and converted the initial cap into a flap, akin to the flex procedure. This was then reflected, the flap as well as the lenticule complex, and the lenticule was peeled from the undersurface. Getting the right delineation of the posterior plane first is one of the challenges in the beginning for a novice surgeon. Even experienced surgeons can have difficulties in cases such as very thin lenticules, like Dr. Gaurav sir had just mentioned, or cases of suction loss, or ones in which the femtodelivery might be inadequate with patchy OBL. What happens then is one may get the posterior plane first, because of which the lenticule may remain attached to the overlying cap. The challenge now is to get the anterior plane. This can be done either with the forceps, as is shown in this case, or with a sharp-toothed instrument. Once this first area of separation is achieved, one can then continue the procedure as normal. Numerous signs, such as the white ring sign and the meniscus sign, have been described, wherein the position of the instrument vis-a-vis the lenticule edge gives you an idea as to where you are. What we practice clinically is something called the stop sign, which is nothing but a stop or a resistance to the lateral movement of the sharp-tipped instrument at the junction of the delineated and the undelineated areas at both the anterior and the posterior plane. This is a contrarian video wherein you can see that the surgeon has gone on for a posterior lenticule delineation at both attempts. You can clearly see the margin of the lenticule overlying the blunt instrument. And at the second dissection, you'll see, since it's in the same plane, there is no stop sign or absolutely no resistance to the lateral movement. Retained lenticules are visually important complications, especially when they're larger or central remnants. Now, these large ones can easily be picked up, be it either on a tomography or the AIOCT, or even a simple dilated retroillumination. These should be removed at the earliest, because later they could result in fibrosis and scarring with certain difficulty in removal. But what do you do with these cases, wherein you can see there's a irregularity and a steepening on the curvature? However, the AIOCT or the slit lamp does not delineate the lenticule well. So what we do is we publish the use of a wash with triamcinolone, wherein you can see that these crystals will beautifully stain the edges of the lenticule, which can subsequently be removed. The important caveats to remember here is to do a thorough wash after you're done, so there's no crystals left behind. One should spread out the lenticule, as in all cases with complications, and make sure that it has been removed in entirety, and the use of a preservative-free solution is recommended. Smile is biomechanically superior to LASIK because the superior and the mid-peripheral collagen is left intact. But as has been mentioned by the speakers before, the guidelines should not be different from that of LASIK because as of now, cases of ectasias have been reported even following normal corneal tomographies. Epithelial ingrowth would have a lower incidence as compared to LASIK because obviously the epithelial handling is lower. But this is a case where we saw a visually significant growth about 6 months post-operatively. You can see that even 6 months later, one can open the initial corneal side cut. We go on to scrape the epithelium and do a wash with mitomycin C. The use of the Circle software to convert this cap into a flap, which can then be lifted, has also been published. This unilateral fungal keratitis is an exceedingly rare complication, but the only advantage of the SMILE procedure here is that you can actually administer the antifungals into the pocket and allow a much deeper penetration, which is not possible topically. This is the last case. It's a sterile infiltrate following SMILE, which was noted about 5 days post-operatively. Now, how you distinguish it from an infective infiltrate is the fact that you can see a clear intervening zone between the limbus and the infiltrate. There's no epithelial defect. The eye was relatively quiet, no anterior chamber reaction. The only complaint was a whitish ring from the patient. So the patient responded very well to topical steroids over a course of months and attained an unaided vision of 20/20. So I'd just like to conclude that there are certain unique complications with SMILE, as there are with every procedure, but a meticulous planning and management can give you optimal visual outcomes. Thank you.